talking about. And this is a 60-year-old man with severe COPD, and he asked your opinion on whether he can fly from New York to San Francisco. He has shortness of breath on exertion, no co-morbid disease. He did have a recent exacerbation of his COPD, but now this is a few months later and he's doing okay at home. His lungs have decreased breath sounds. You did get pulmonary function tests on him. His FEV1 is 1 liter, which is 33% predicted. And the FEV1 FVC ratio is 45%. So, given those two values, how would you classify the severity of his COPD? Okay, he would be very severe. If you remember, the first number you look at is the ratio, which is the FEV1 FVC, and that's less than 0.7. And I always hate it when they give the percentages like that. So if it's less than 0.7, his is 0.45. And then if you look at the FEV1 percent of predicted, so you know he's obstructed, and the percent predicted is 33%, so he's in a severe COPD classification. Less than 30% would be very severe, 50 to 80 would be moderate, and above 80 would be mild. So you do his PFTs and you get a blood gas, and his pH is 7.40, his PO2 is 65, and his PCO2 is 40. So are you going to tell him it's okay to fly, or are you going to have him take a bus cross country, taking the sights as you go through?
Yeah,
so
increase the oxygen.
All right. We'll come back to how you do that. That's not, it's easier said than done. So, this is a lot of writing on this slide, but this is these are essentially the rules that Medicare has set forth in terms of who they will pay oxygen for and who they will not. And basically all the insurance companies follow the same guidelines. Essentially, what it says is that if you do a oxygen saturation and it's 88%, you qualify for oxygen. Or if you do a blood gas and the PO2 is 55 or less, you qualify for oxygen. Now, so are those just arbitrary numbers that they came up with? And the answer is no. They actually did do some looking into how to come up with these criteria. And there are two landmark studies that were published. One was published in 1980 in the American Annals of Internal Medicine, and the other one was published in 1981 in Lancet. And these provide the bases of how we prescribe oxygen today. And what they did was they had, there were two trials, the NOT trial and the MRC trial. One was in Great Britain and the other one was in North America. And if you look at, for example, the nocturnal oxygen trial, one was 24 hours per day, one group, and the second group had 12 hours per day. And you can see that after 3 years, there's a difference in mortality between the two groups. The MRC trial gave patients oxygen either 15 hours a day or they didn't give them any oxygen at all. And so the control group for the MRC trial is down here, and the oxygen group is up here. And eventually they stopped these studies before they were fully into their fruition because of the clear benefit in mortality that they had in these COPD patients by administering oxygen. And the way they selected the patients who got oxygen and did not were to look at the PO2. And that was before the days of readily available oximeters. And so they used a PO2 of 60 as their cutoff. about a saturation of 88%. And the reason they chose a PO2 of 60 as the cutoff is because at 60, you can see this is the relationship between oxygen level saturation and the partial pressure of oxygen. And if your PO2 is 60 or above, you're 90% saturated. So your oxygen carrying capacity is really pretty good. But if it's less than 60, that's where you tend to fall off the steep part of the curve here. And it was thought that these patients could get quite hypoxic. And it was also thought that this is where you develop pulmonary hypertension if your PO2 is less than 60. So back in 1980, that's what they used as their criteria as to whether they were going to prescribe oxygen or not. As it turns out, the groups that died didn't have any higher incidence of pulmonary hypertension, so that really wasn't a factor. But as it turns out, it does have a profound impact on mortality in these people, and that's why Medicare has set their guidelines the way they are today. So this is probably a familiar chart to most of you. This is when you order your oxygen needs assessment. What we do is we initially we'll make a saturation measurement on room air, and in this case, the oxygen saturation is 90%, goes in the circles, and the exercise saturations are the X's. So you can see with this patient, when our technician got him up to walk, and I think this patient walked about 60 yards, there was desaturation to 85%. So how would you prescribe oxygen in this individual? Or would you?
Yes.
Yeah, so he desaturates with activity and certainly would deserve oxygen when moving about. And you can see that the technician then measured his oxygen saturation again on 1 liter per minute, and he comes up to a good range. Now, Medicare wants documentation that the oxygen saturation is 88% or less, so you have it. And they also want documentation that the hypoxemia improves, so that if you give oxygen and it doesn't get any better, they're not going to pay for it. And so we do repeat the O2 needs assessment, and so we document again that the oxygen saturation is about 90%. So this patient would be well suited to get a system for delivering oxygen at home. How about your second group who kind of falls in the gray area? Their oxygen saturation is 89%. It's not 88%. Well, you can still justify oxygen with them if you show some other organ compromise. And typically, what we look for is evidence of dependent edema, suggesting congestive heart failure, pulmonary hypertension, either by P pulmonale on the EKG, or a high hematocrit greater than 56%. So if you have someone with oxygen saturation of 89%, you can still prescribe oxygen if you meet one of those criteria. So they also have guidelines on oxygen and travel. So if you're a patient and you want to fly from New York to San Francisco, you're responsible for getting your oxygen supplied. If you want to stay in San Francisco for a month, your oxygen company in New York or Rhode Island cannot receive any money while you're in San Francisco. They will only pay one bill per month for oxygen. So the easiest way to do this is to have an oxygen company that's national. And so they have an office in Rhode Island and an office in San Francisco, and therefore they can get their billing straight. And but if you decide to have two different companies, then you're responsible for paying for that. Oxygen services furnished by an airline to a beneficiary are not covered. So you call up United Airlines and you want to fly from New York to San Francisco, Medicare is not going to cover that added cost of oxygen for your flight. It will come out of your pocket. And by the way, the airline, if you have to stop at Chicago to change planes, the airline is not responsible for what you do in the terminal. You're on your own for oxygen there. So hopefully you don't have a long layover. But you will be at sea level in Chicago. So we get back to our case. And so what would you do next? And this is a question from your MCSAP pamphlet. Your choices are advise against the flight, schedule a hypoxic inhalation test to simulate an altitude of 8,000 feet, recommend flying with supplemental oxygen at 2 to 3 liters per minute, calculate the estimated PaO2 using your regression equation, determine the airline's policy on the use of supplemental oxygen. So this guy really wants to go to San Francisco, stay with his grandchildren for a month, and does not want to travel Greyhound. So what are your choices?
Hypoxic inhalation test?
No, supplemental oxygen to 3 liters.
You hypoxic inhalation test. You're going to need a hypobaric chamber, and so you're not going to do that, or you just breathe a low mixture of oxygen. The easiest thing is to get out your pencil and paper and do some math and calculate based on regression equations what his PO2 would be at 8,000 feet. They used to pressurize the aircraft to 6,000 feet, but I guess it's a little bit less costly to do it for 8,000. So I'm just going to quickly show you this. These regression equations basically take into consideration your altitude and the barometric pressure. And so what you do is you can use the alveolar gas equation, which you do use when you calculate your AA gradient, to come up with a fraction of inspired oxygen. And so, for example, at 8,000 feet, which is where the red line is there, your barometric pressure will be about 580 or 560 torr. So you can use that information then to calculate what you would expect the inhaled oxygen to be in your patient. But just knowing the FiO2 isn't the whole story, and you can see that the first part of this curve here, this is at 6,000 or 5,800 meters. This is at sea level. The inspired oxygen, there's a big difference. And when you add humidity to it, so water, there's another decline from here to here. Then there's another big decline when you go from the trachea to the alveolus. And then when you go from the alveolus into the capillary blood, there's another barrier to oxygen, and then finally to the tissue. So that along the way, there's a number of steps that in which your oxygenation decreases as you're going from the ambient air that we're breathing all the way down to the mitochondria that are using the oxygen. And if you remember your alveolar gas composition, 20 breathing room air, 21% is oxygen, a little bit of carbon dioxide, some water vapor, but the bulk is nitrogen. And as you're going from the mouth or the upper airway to the alveolus, the major difference here in terms of why oxygen goes down is the carbon dioxide content. And I always have to show this slide of the bar-headed goose. whose migratory route is over the Himalayan mountains. And so these guys are flying and exercising at 35,000 feet, and they don't get hypoxemic. So it's just pretty amazing physiology. Whereas if you wanted to climb the summit of Mount Everest, you would usually have a Sherpa with you carrying oxygen tanks so that you could make it to the top. So, impressive animals. And this is just one of the regression equations. It's 0.24 times the PaO2 plus 20 times your ratio plus 22. Definitely don't memorize it. This is something you look up in the book. But what we do with our patient here is that we calculated that even though his PO2 is 65 at sea level, when he goes to 8,000 feet, he's going to drop to 46. So he does need oxygen, and probably you would order 1 to 2 liters per minute of oxygen for him. Just some of the airlines that allow oxygen concentrators, most of them don't. And so now you have your patient that you want to set up with a system at home, and you have a few different choices of how to do this. In the hospital, you don't worry about oxygen because it's piped in and we're not paying for it other than under the whole budget for the hospital. But at home, there's two different ways you can go. You can either get tanks of oxygen, or you can use a compressor or a concentrator. These are your tanks of oxygen. Green is the color for oxygen. Though I don't know what the other gases are there, but those are the big H cylinders that we used to have lined up in patients' home. And one of these cylinders might last a day, and so the oxygen company would deliver 3 or 4 of them and come back every couple of days, putting a tank in. That's okay for the patient, but it costs a lot of money for the oxygen supplier driving these trucks all over town every couple of days. There are smaller cylinders which are for portable, so that typically what happens in our patient who only qualifies during activities, they would get one of these small tanks with something to wheel around. And you see these being used by transport in the hospital all the time. Patients don't like that. They're short of breath to begin with, and then you give them a heavy tank to push around, and they'll always come back asking you for something smaller and lighter to use. And so we have a smaller tank here, but it's still compressed gas, and it will only last a couple of hours. The other thing is, if you have an empty oxygen cylinder, always label it as empty because you don't know, but just by looking, whether it has oxygen in it or not, and you don't want to give it to a patient that is empty. If you look for liquid oxygen on the internet, you will find a bunch of different interesting things that will pop up. This one is liquid oxygen. You take a tablespoon a day, and it's got colloidal silver in it, and it's supposed to be good for you. What I was looking for was a different kind of liquid oxygen. And these are the systems that patients like for portability because they're small. And this one weighs about 5 pounds when it's full, and it will last about 5.5 hours when it's set at 2 liters per minute. So this is a pretty good system for patients to use if they're ambulatory. How do you get those? And this is a picture of how small it can be. Basically, the other part to that is a very large cylinder which stays in your house, and it's filled with liquid oxygen so that you refill the tanks yourself. You put one tank on top of the other, and you fill it. And the company has to come by maybe once every week or once a month to fill the liquid oxygen tank, depending on how much you use it. Liquid oxygen is a little bit more expensive than the compressed gas. And probably the most commonly used system is the oxygen concentrator. So it looks like a little refrigerator. You plug it in, And what it does is it takes the room air, and it has a membrane that separates the nitrogen from the oxygen. And so you're left with a reservoir of 100% oxygen. And you can deliver flow rates up to 6 to 8 liters per minute with this device. So it really filters quickly. It eliminates the nitrogen. The problem with this device is that patients always come back and say, my electric bill went up by $50 to $60 per month because can I go back on the gas because I don't have to pay for any electric bills that way. But the home care companies love this system because they drop it off and they're done with it. The patient becomes responsible for it. And this is another liquid. Not liquid, it's a concentrator, but it has a fill system, so you can take a tank and you can fill it with oxygen from the concentrator. So that probably 5 or 6 years ago, if you had a concentrator, you also needed liquid oxygen if you wanted to get out of your house. Now you can have a concentrator and refill from the concentrator and not have to have two different systems. Portable concentrators go everywhere. They're good for cruise ships, good for golf, good for driving, and so people can have a lot of freedom with them. But I can tell you that although the airlines will allow concentrators on their planes, you need to buy 2 tickets, one for you and one for the concentrator to sit next to you. They weigh about 17 pounds, and I've had a couple of patients use them on the planes because, and it's worked out quite well, but they do take up a lot of room. And when the flight attendant says, place everything under the seat in front of you, you're not going to be able to squeeze that in, and you don't want to put it in the overhead bin. Because if that shifts around during flight, that could be big problems when everyone's rushing to get around. So the oxygen concentrators are good for travel. And the big benefit in the airlines is that you go to the terminal, you're waiting in between flights, and you can still run it. You can charge your batteries, where everyone's got their computers plugged in, you can plug in your concentrator. Now, some patients won't be able to get a portable concentrator, and so then you're left with buying the oxygen from the airlines to do the flight. That can also get quite expensive to purchase the oxygen on board. The airlines do not want you taking your own oxygen tanks on the plane. Talk about an explosive device. You don't want somebody sitting with an oxygen tank next to you. So that's sort of a brief review of different oxygen delivery devices and some of the rationale